So, last talk of the morning before actually the break is my pleasure to introduce my friend Christian Virchow from Germany, Switzerland, some part of Italy too. And I know that it will be provocative as usual. And so the topic is severe asthma 2024. Christian, go ahead.
Thank you very much, Walter. Ladies and gentlemen, dear colleagues, a great pleasure to be here, great honor to speak among such distinguished speakers. My prejudice about guidelines, I must say, after these two wonderful talks is the more people you have in the guideline committee, the less people will be reading the guidelines, because it becomes sometimes a bit too complicated. My task is with you now to think a little bit beyond what is currently in the guidelines, because Arzu very nicely told us she always needs evidence, and I'm trying to provide you some ideas where we should be moving forward and in which direction. This is my conflict of interest statement, and the content of my talk will be, first of all, and you know this is relatively important for us, how useful is asthma severity to guide treatment. And we look at two case reports which try to illustrate this. And then we look at remission asthma again, and I think some people call it complete remission. We like to think of clinical versus biologic remission, because I think it is very important that we as asthma specialists or pulmonary specialists try to begin to speak the same language as other chronic inflammatory diseases, because there is a lot of overlap, and we talked about multidisciplinary teams, and we talked about the virtue of integrating ideas in different inflammatory diseases in order to move the field forward. And then I'll look quickly at some new data on anti-interleukin-5 therapy for every 6 months and anti-interleukin-5 therapy for acute severe asthma. Now, my problem with the guidelines, Arzu, is that we have these two important developments circled in red. We're supposed to treat, which I think is a very good idea, in mild asthma, patients with inhaled steroids and formoterol combinations and nothing else, and we should not be using, unless we're in sub-Saharan Africa, not be using the below line. And then we have the other important addition that we should be using or looking for the treatment of very expensive biologics before we use oral corticosteroids. Now, the problem, however, and if I go back here once more, is that the guidelines, unfortunately, still, and we are in Germany looking to change this completely, that we're looking at step 1, 2, 3, 4, and some guidelines are even looking at steps 5 and 6, and we should be considering whether this is really useful, because asthma severity here is defined by the level of treatment required. On the other hand, the level of treatment defines asthma severity. That's what we call in Germany the cat bites into its tail, going around in circles like this snow leopard here. It is not really very useful. And therefore, the very important question I think it is, and sort of think a little bit beyond what you're doing in practice every day, just think a little bit more theoretically. Is it really helpful to say someone has mild asthma or someone has severe asthma? And are we just, if we say this, are we just looking at a particular point in time, or are we looking on months and years or even a lifetime? Because we all know that this can change significantly. Look at this one case report here. This is a gentleman who has, as you know, this is a body plethysmograph. This down here shows you that the airway resistance is massively elevated. Residual volume is 3 times of normal. The vital capacity is reduced, and peak flow is about 30% of what is supposed to be his normal value, which is up here. Now, this is a 24-year-old male with persistent severe dyspnea and cough, which increased after he was at a party with alcohol and a bicycle ride home in June of 2022. Now, I don't know what he smoked at the party, but he saw me with this lung function. He had received 250 milligrams of prednisolone 2 days earlier. Now, is this steroid refractory asthma? His FEV1 was 33% of predicted vital capacity, 51% predicted residual volume of 301% of predicted. Now, we all agree this is severe.
Is it severe asthma? That is the important part. But his FeNO was 123 parts per billion, and the eosinophilia was 1250. Now, Santiago would have immediately given him an anti-interleukin-5 because he has 1250 eosinophils. Sorry, Santiago, I'm joking. Yeah? And other people would give him Dupixent because his FeNO was 123. Yeah? However, and I think this is a call, we should not be looking too much at biomarkers are important. They make us better doctors, but we should be good doctors first before we use biomarkers, because we need to look at this patient further. His skin prick was highly positive for birch, elder, hazel, oak pollen, and grass pollen. In June is the grass pollen season in Germany. His specific IgE was 6, the highest class against birch, elder, hazel pollen, highly positive for grass pollen, which is not quantized. And I started him up 12 days of prednisolone 20 milligrams, which David Price would say, this is dangerous, this is deadly, yeah, you die if you take 20 milligrams of prednisolone. This is the patient, Arzu, coming back 14 months later. No symptoms, FeNO 17 parts per billion, no eosinophilia, lung function, as you can see. This is the same patient. Lung function is completely normal. And he takes, to please me, he says, I take 1 puff of ICS-LABA just before I play football. Actually, I don't need it. Now, does that patient have severe asthma, or is this asthma in remission? And is it not much more important to see whether the asthma is not in remission, or whether it's severe or mild asthma? And do we do this patient, this is the next slide here, the other thing, the patient has received a sublingual immunotherapy against birch pollen, interestingly, and he says, my allergies have become much better. So is he maybe in remission even off treatment, just because he takes ICS-LABA to please me? I'm sure he didn't take it, actually. Yeah. So are we doing this patient, his referring physician, ourselves, and the healthcare system a favor labeling this patient as mild or severe, or acute severe, or acutely actually mild? It doesn't make any, at least for me, it doesn't make any sense. Yeah? And I know that you are all having your hairs going up in the back, thinking this is completely crazy. But let's look at another case report. This is a 55-year-old lady. She has recurrent exacerbations every month. She doesn't come, Walter was saying, I have an exacerbation. She goes to hospital and receives systemic steroids. Yeah, she wakes up 3 times a week at night. She has severe exertional dyspnea. She works as a waitress and coughs all the time when she serves the food, which is not very pleasant for the guests either. And she has severe agonizing cough. Yeah. Laboratory, her IgE is 393 units. All specific IgEs, however, remember the talk by Joanna, were negative. Her peripheral blood eosinophil count, however, is 3,620, despite receiving maintenance treatment with 5 milligrams of prednisolone. Now, we would agree at the moment, the guidelines would say this is severe eosinophilic asthma. We call it severe, or we call it intrinsic asthma because it's adult onset, and her FeNO is 49% of predicted with 5 milligrams of prednisolone. This is her multiplicitosmography. You can see here residual volume almost twice as normal, vital capacity reduced, peak flow halved, and this is with 5 milligrams of prednisolone at 3,600. Now, treated for 5 times, in this case it was reslizumab, but I could have taken any other biologic because we know that they work sometimes very well. Her lung function, even at the age of 55, and despite the fact having received 5 milligrams of prednisolone for years with recurrent bursts in between, her lung function becomes completely normal. It is 105% of predicted, and she doesn't need any prednisolone anymore. And she doesn't take her inhaler anymore. Yeah? Because she says, I'm cured. It's like I never had the disease. Now, does that patient have severe asthma just because she requires a treatment which is very expensive? Are we defining severity according to the price of the treatment? Or are we defining severity based on the price of side effects of treatment? Just because he needs an expensive biologic, or have we achieved remission because we received the correct treatment using a personalized approach? And this is what I'm trying to make a point. We need to personalize treatment to the individual patient's needs. and not according to the severity. That's my point here. In other words, have these patients received personalized treatment they needed to induce remission? And therefore, again, the question, how useful is severity in this context? Of course, we all have a picture in mind what we consider to be severe, but I think we should not be using it in terms of a definition of asthma, and especially not as a definition of treatment requirements long term. So in other words, why does a patient who achieves remission with a biologic monotherapy have severe asthma, and a patient who achieves remission on ICS-LABA have mild asthma? They both achieved remission with the appropriate treatment. So I think this is very important and very down to the point to do personalized treatment in asthma, and not use a one-size-fits-all. So I think in 2025 we should change the concept, and we're thinking about this in Germany, how to put this and phrase this in guidelines so that people can understand and read it. Not according to severity, but according to pathology, asthma treatment should be, should be treating to target, the treatment target being remission, and this requires personalized treatment. And we have therefore, together with Walter, of course, and other experts, come up with the idea also to speak the same language as other chronic inflammatory diseases. This is all borrowed or stolen from the rheumatologists. Disease-modifying anti-rheumatic drugs. Why should not we be talking about disease-modifying anti-asthmatic drugs, which is the DMARDs with 2 A's? The idea, a disease-modifying anti-asthmatic drug is a drug class or a drug that can potentially achieve the goal of asthma remission. And from this, we can change our concepts from moving away, as the GINA guidelines do, from rescue medications, short-term relief of symptoms, which includes control. For many, ARSO control means immediate action and a short-term intervention. I want to control the riot, I want to control whatever the fire, but it is not necessarily implying long-term action. But the important thing is we want to modify the disease, which is not cure. Modifying the disease means to interfere with underlying pathologic mechanisms of a disease to achieve remission. And this requires individual treatment and not a one-size-fits-all approach where we use inhaled steroids or systemic steroids, which seem to work in everybody. So in the past, this is the concept that GINA still has. We want disease control, where phenotyping still is somewhat optional. You don't necessarily have to do this. You can be very lazy and don't do any phenotyping. You give drug A, it doesn't work. You add another drug, it doesn't work. You add another drug, it doesn't work well. Even in the end, you end up with 4 drugs, which is many drugs, high doses, many adverse effects with a high treatment burden. However, we don't want, or we should not be doing this approach anymore. We should be going with a concept of disease modification, where phenotyping is absolutely essential. We can go wrong with phenotyping, and sometimes we have to refine it, and sometimes we have to change this during the course of treatment. But we want to identify and treat with the most effective disease-modifying anti-asthmatic drugs. And with this we call the induction of remission here, in which, of course, Walter has also been very instrumental in this paper here. Induction of remission, so to get whatever the patient's personal best is, and then we want to maintain remission by reducing drugs to the lowest drug burden that the patient can maintain remission at. So we want few drugs, lowest possible dose, minimal adverse effects with a low treatment burden. And this requires individually tailored treatment according to the patient's phenotype, or I should say to the patient's pathology, and not to the patient's severity. This has been shown just recently in a study which I think is overhyped. It's called the Shamal study, in which they tried to reduce inhaled corticosteroids in patients who were put on benralizumab. And as you can see here, Arzu, 61% of the patients who were put on benralizumab didn't require any other treatment. They stopped their ICS-LABA treatment completely. And I think they were right so, because apparently the underlying asthma Inflammation in these patients was well controlled. There are caveats to this study because there was a bit of a reduction in lung function and an increase in FeNO. That needs to be discussed. There will be other studies on TSLP, which is called the Arrival study, which interferes with FeNO and eosinophilia, and we'll see how many patients can reduce their inhaled therapy completely. But a vast majority of these patients were able to reduce their treatment to a monotherapy, which is, of course, off-label at the moment, but I think we need to think about this and change this. So I think when we come to this is our sort of retaliation or approach against guidelines, which are 892 pages long, which nobody reads. It should be very short. It should be basically a one-pager, which we call the A to BCD guide, where A is assess, diagnose, and phenotype, and then assess current control and risk, because that, of course, identifies what you need to induce remission. But then you look for basics like inhalation therapy. Arzu has nicely talked about this. We look at comorbidities, but most importantly, at the end, we look for D, which is treat with disease-modifying anti-asthmatic drugs with the aim to induce and maintain remission. No symptom, no exacerbations, no oral corticosteroids, minimal treatment-related adverse effects, and a stable lung function once you have induced remission. Of course, once you have induced. While you induce remission, you may also try and think about improving lung function, which doesn't work in all patients. I had a few more slides, but this is not working anymore. Oh, here we go. Now, when we think again about the concept, and I think also this needs to be refined, and Walter and others and I are working on this, we want to move from disease modification with the aim of remission to this first very important part of clinical remission, which can be partial, as our Italian colleagues published, when you have any of those missing here, with the exception of oral corticosteroids. If you don't get rid of oral steroids, you're not even in partial remission. And you're in complete clinical remission if you meet all four of these criteria. Of course, this needs to be discussed. This needs to be corroborated by appropriate science, real-world studies, and so on. But we need to also understand what we talk about when we talk about symptoms. I think this is a very important study by Marek Lomacz, where he looked at patients for the question, what does symptom mean? And we need to be good doctors to understand why our patients are having symptoms. And interestingly here, patients who are overweight, this is the black group here, who have a body mass index of more than 30, they're much more likely not to achieve remission due to the fact that they maintain symptoms. But we need to understand, is the symptom in terms of breathlessness due to asthma, or is it just because they're overweight? Yeah, and I think this requires more than biomarkers. This requires clinical understanding of patients with asthma. So again, we need to be good doctors to understand this. But from there, I think the next important part is that we have to look at biologic remission, such as the inflammatory bowel disease people do. They do biopsies of the colon and say, oh, there is no inflammation. Now we are even in biologic remission. Well, we have surrogate parameters such as eosinophilia, FeNO, mucus plugs is a new one, or possibly even bronchial hyperresponsiveness. And when we take this together, we need to understand what has to be changed here to induce and maintain clinical remission, and how do changes here or here actually interfere with prognosis of our patients. And this will come up, I think, next week in the Lancet Respiratory Medicine. We can talk about the clinical remission, three-component definition of no symptoms, no exacerbations, no steroids. We prefer for clinical definition the four symptoms, which includes stable or normal lung function. But from there, we will have to go and look at biologic remission with low type 2 biomarkers, normal airway hyperresponsiveness, possibly even including mucus plugs, to have a more comprehensive picture of what we're looking at when we talk about severity, or at best, what are the defining features for remission, for achieving remission and maintaining remission. What's new? Very quickly, there will be available, and I don't know at the moment where I will position it with my patients, a anti-interleukin 5 treatment which works for 6 months, and it's called depemokimab. And this is the study here, a 2-arm study with 2-to-1 randomization to this depemokimab or placebo, and what they found was that this is the first 6 months, and then this is the second dose here, and there was a significant reduction in exacerbations on the 100 milligrams of depemokimab, which would allow patients to see you only every 6 months in order to achieve similar results as with other anti-interleukin-5 therapies that we have at the moment, which we give every 4 or every 8 weeks. The exacerbation were reduced in these two parallel studies, SWIFT 1 and SWIFT 2, basically exactly the same studies by 58 or 59 or 58% reduction. And when we look at the subgroup analysis, the interesting findings, I think, is it works in all subgroups with the exception of, nope, that was not good. I need to go back. With the exception of, actually I thought this was animated, but it isn't. With the exception of young children or adolescents, and this is something that our pediatric colleagues tell us, although mepolizumab is licensed for children, they simply don't see these patients that could be put on because these patients are not available or it doesn't work in these patients. It also does not work very well, apparently, in patients who have low eosinophil numbers. There may be some patients who have T2 asthma with suppressed T2 markers, but if you don't have T2 asthma, it cannot work. And the other interesting study was one which came more by accident because they had a patient in this clinic here by Dr. Ramakrishnan who was not able to tolerate systemic steroids when he had a severe asthma attack. So they still had somewhere in the freezer or in the fridge, they had 100 milligrams of benralizumab, which they used for another study. And they thought, why not give this to this patient? And the patient did miraculously well, and therefore they designed a study where they looked at prednisolone, 30 milligrams, and benralizumab in 100 milligram high dose, or prednisolone plus placebo, or placebo plus benralizumab alone. So it's steroid plus benralizumab, steroid alone, or benralizumab alone for the treatment of acute severe asthma, 18 years up to 72 years, one exacerbation in the previous 12 months, a eosinophil count of more than 250, and an acute exacerbation, they should have had more than 300 eosinophils. This is the patient population here. Interestingly, they also included COPD, but luckily only very few patients. But and they had patients with asthma and COPD, which of course can occur. Interestingly, the blood eosinophil count was 690 up plus minus 600 to 790, 520, 610. So high eosinophil count, which suggests these patients did not have COPD, but they probably had asthma. And the FeNO level also corroborates this high FeNO levels, again suggesting that it's asthma and not COPD. But the interesting finding was that in terms of treatment failure, 73% of the patients failed treatment within 90 days on prednisolone alone, while benralizumab pooled with or without prednisolone did much better. And the same was with the visual analog scale in terms of how well did the patients feel. More patients felt better when they had received the combination or monotherapy with benralizumab, and this is also the time to treatment failure as a secondary outcome, which I would have taken as the primary endpoint of a study if I would have had to design it. Much fewer or much less patients exacerbating or having treatment failure after this treatment on benralizumab than patients on prednisolone, suggesting that in the future we might be able to use this as an acute treatment. Subgroup analysis suggested that it doesn't work in patients who have asthma and COPD. Maybe this is due to the COPD component, and it doesn't work well in current smokers, again suggesting that it does not work in those patients who actually do have COPD, and it does not work in those patients who have low FeNO levels, again suggesting that they are looking at COPD patients who will not respond to benralizumab. This is why I put the COPD up here in brackets. Okay, this is animated, sorry. So in summary, severe asthma severity, I think, is not at all helpful in order to guide therapy unless we're thinking about the acute phase that we see the patient in. Personalized approaches are absolutely necessary to determine individual patients' minimal requirements, and the new treatment aim is not control, ARSO, I'm very sorry, is remission. Clinical and biological remission should be included in our vocabulary when we talk about asthma in the future in order to be able to speak the same language as other disciplines who have been looking at this much longer than we have. And the future is anti-interleukin-5 therapy with high eosinophil counts every 6 months seems to work, and it might even be useful for acute severe asthma, being more efficacious than prednisolone. And with that, I thank you very much for your kind attention.